Start then. So, everybody, welcome to Bath Pain Forum. I'm sorry if I'm being repetitive for some of you, but this is a quarterly open lecture series run by the Bath Centre for Pain Services, where I am, which is a UK national specialist service where we treat young people, young adults, adults with very disabling chronic pain. So, I'm Jeremy. I'm one of the service leads here, and I'm going to be emceeing here today. And I will introduce our speaker in just a second. So we've got some people still coming into the waiting room. I think you guys all have screens and mics disabled, so I think that's fine. And we are recording this, so that's just a heads up for the people that may have missed it, and we'll make that available for a short while afterwards. So David, is it okay if I go and give you a couple of words of introduction? So, so David, it's great to have you as such a long-standing colleague here speaking to us. It's much appreciated. So Professor David Wynick is Professor of Molecular Medicine at Bristol University and still works as a consultant in pain medicine at the Bristol Royal Infirmary. And David's a huge figure to us locally in coordinating research across the Southwest region. So he's director of the Bristol Health Partners Academic Health Sciences Centre. And I think you're also director of the NIHR Bristol Clinical Research Facility, David, is that right?
Correct.
Okay, well, look, I don't know what other honorifics to say, but it's just really nice to have you here, and please do take it away.
Well, thank you very much indeed, Jeremy, and indeed the whole team for inviting me. I mean, I've been to many of these, but it's I think only the first time I've been invited to speak, so I'm honoured, and I'm going to share some work with you, only some of which I led. As I go through it, I will, I hope appropriately, highlight people who've had fairly major contributions to all of this. You'll notice on, I'm just realised I haven't shared my slide yet. That's good. Jeremy, has that come through okay? Yeah, good. So I'm presenting this on behalf of the Bristol Health Partners Chronic Pain HIT. HIT stands for Health Innovation Team. It's where we bring together clinicians, patients, and members of the public with researchers and commissioners all around a focused area. It may be one particular speciality, for example, chronic pain, or it may be a much more broader, knotty, cross-cutting theme that everyone has put up till now into the too difficult box, and we'll come back to that. Well, we try and build teams to address these issues. So it's only really been very recently, well after COVID, that people have started saying, well, from an epidemiological point of view, how on earth do you measure chronic pain? How on earth do you identify those who have chronic pain when it's nearly 50% of the population? Certainly when we designed the chronic pain questionnaire that was rolled out across the 500,000 at Biobank, we again struggled with exactly the same thing. And there we went for self-declaration. And essentially we said to people, have you had pain for more than 3 months? But because that involves such a huge number of people, over the last 5 years, we, and indeed others, in very much parallel evolution fashion, have tried to identify ways to look at those who have moderate to severe pain, which after all are the ones that we will tend to see in primary and secondary care, and where we'll be thinking about various treatments, whether it's medication or psychological pain management programs. And we picked upon, in the end, and there's multiple ways of doing this, but we picked upon medication. We took the view that if you had moderate to severe pain, the vast majority, not everyone by any means, but the vast majority will be on one or more prescribed analgesics. I'm not talking about over-the-counter, I'm talking about prescribed analgesics. So we pulled together a very comprehensive list based upon actually the Cambridge Multimorbidity Scale, which has been around for ages and also had a list, but essentially it was all of the opioids, all of the non-steroidals, all of the neuropathic pain drugs, but we excluded migraine and gout because although, of course, they do cause pain for more than 3 months, they are very, very different to what we're talking about. So we had all of the usual suspects, all of the opioids and the non-steroidals. We excluded also those that were on disease-modifying drugs for rheumatoid arthritis. Yes, of course, many of those will have pain, but they will be on the current medications. The other thing we did was we set a cutoff of 17 because that is the definition from the system point of view of an adult. And lastly, we excluded those who were on a recognized, documented end-of-life pathway. Because again, it's a very different group of people, those who are in effectively palliative end-of-life care. So what I'm going to share with you now is our analysis, first of all of that. So I have skipped over really the first background slide because I think you all know this. Many of you probably far better than I. The only paper I think that is worth highlighting is the recent analysis, and it came out about 3 years ago now, of 41 GP practices in Lambeth. And essentially, they did the same as us. They used all of those medication, but they were also very clever because this was done on an entire at-scale population in South London, about 1/3 of a million in primary care. This is very, very analogous to what we do in Bristol, North Somerset, South Gloucester with our system-wide data set of 800,000 adults, 1.1 million in total. So they took the drugs, almost the identical list that we did, one or two terribly minor variants, but essentially it was the same list. And they came up with a whole list of chronic pain diagnoses. And they assigned to them a level of importance. So, for example, if you had clear osteoarthritis or inflammatory arthritis, or a diagnosis of fibromyalgia, then you would get a high score. And then there were a whole load of other symptoms where clustered would definitely make the cut, so to speak. And there are some where, yes, sort of in most patients, and then they combine that with drugs. So if you've been on drugs for more than, say, 3 prescriptions or 4 prescriptions. So they came up with a whole algorithm that brought together all of the medication and all of the diagnoses. To be quite frank, it was far more complex and requires, a computer, for want of a better term, to calculate it all. But at the end of the day, they found 16.6% of the population had that level of chronic pain. In other words, they required drugs and they had the diagnosis. That's more than we got in our findings, which was about 9.4%. So that makes the point I was really alluding to before, that obviously there are patients with chronic pain who have moderate to severe chronic pain, but are not on medication. There's a whole obvious list of reasons why that might be. They've tried the drugs and they didn't like them. They've tried the drugs and they worked, but unfortunately the effects wore off. But the group I worry about the most are the ones where they've never been offered drugs, and yet they quite clearly have significant limitation. Now, within that, obviously, will be a heterogeneous group. There will be some that will say, well, I don't want any medication, and we've all seen patients like that. But at the same time, I am concerned that there is a group of patients who, on the whole, tend to come from unequal backgrounds, who come from poverty, where English may not be their first language. And you can imagine a scenario where, in that case, the patient is not properly understood, and or the GPs, who are all busy, haven't got enough time to go through this in detail. And as a result, that patient's chronic pain and its impact on their activities of daily living will be considerably underestimated, and they don't get those drugs. So I think there is a definite reason for that. And the last one, I'm going to say this, and it's not directly evidenced in our own practice, I'm pleased to say, but there will be an element of institutionalized racism. Let's be honest about it, whether it's implicit or explicit, there will definitely be a difference in the way we treat people in terms of medication and being having a detailed discussion, that will be different from different groups of people. I think we all wish it was otherwise, and I think many of us may try to say to ourselves, well, we treat all patients equally. And I say that to myself, but I'm not really sure I do. So I think that is a slightly different but more complex algorithm that was used to really calculate chronic pain in far more detail than we did. And I have to say that we in BNSSG, Bristol and Somerset South Gloucester, have made the decision we are going to use that algorithm. It's EMIS based, which is nice and easy because obviously we're all on EMIS as well, but it can be ported over to the other major primary care provider, and that's TPP, and we're in the process of doing that because, as you'll see, we are also involving inner city Bradford in our plans, and that's probably one of the most deprived areas in the entire country. So we're keen to test what we're going to do there as well. So I think all of that, I think I've largely talked you through the analysis that we've done. So we took our original algorithm rather than the new one, which was just the medication, and we ran it on our entire adult population with the caveats I've already said. And, we identified 9.4%. So that's about 70,000 individuals with moderate to severe pain that requires a continuously prescribed analgesic for a year or more. If you increase that figure to about 16%, 15 or 16%, which is what I expect it to come out at, I'll get the figure in January, but I expect it to come out, if it's 15%, then that number with chronic pain will go up to at least 100,000. That's an awful lot of people. The things below, I suspect you will all know, it's more common in women, it's more common on the whole, or at least it's different in non-white communities. And here there is diversity in the literature. Some people found that there is an overrepresentation of non-white communities, minoritized groupings, and that does not mean, I think, that the true prevalence of chronic pain across those populations is higher. In other words, they don't have different pain perception, but I think there are a host of different reasons why you may find that there are patients from minoritized backgrounds on more drugs. And I would hazard a guess, and this I have evidence for in our system-wide data set, they get referred later, which means they stay on the drugs. Some analyses, as with ours, showed that there was an underrepresentation of people from minoritized communities. In other words, there are less of them with chronic pain that meet the drug definition. And that, I'm sure, is explained by the reasons I gave you just a few minutes ago. They aren't prescribed the drugs. I think that's the thing that's like to make the biggest difference. I can see no reason why, well, there are theoretical reasons, but it's unlikely that that sort of difference will be accounted for purely on the basis of true genetic differences in the way they handle the drugs. And lastly, it's far more common in deprived populations. If you take the PCN WWV, Western Wall and Villages in Western, which is probably the most deprived area in our patch, it has something like 1.5 times the prevalence of chronic pain than in the overall population. If you compare that to, say, Clifton, where it's almost exclusively white and wealthy, then again, the figure is probably fourfold between them. So I think all of that, although it didn't come as any surprise, it was quite stark to see it on such large numbers. I think this page may interest you all more because I suspect you won't quite see this quite so often in other analyses. We looked at working age population. There's more people in working age population with chronic pain than those who have retired or are elderly. And that sort of flies in the face of, oh, I would have predicted it would be the opposite, but it isn't. And that's because it's such a big deal for that population. I think they go and see their GPs a lot earlier. Nearly half of the people with chronic pain also have comorbid anxiety and depression. And that's nearly threefold higher than those who don't have pain. And again, I think for all of us on this call, we'll look and go, well, yeah, obviously, we all know that. All of our patients are more anxious and depressed, and anxiety and depression makes pain worse. So here's some other interesting figures. People who are housebound have over a six-fold higher prevalence. Again, you can think of obvious reasons why. People with learning disability have 2.5 times the prevalence. Those who are homeless have 2.5, and so on. So, when you drill into the details, it's fascinating to look at the subgroups and who they are and their other demographics that go with it. Now we come on to costs. The cost per head of population are enormous in this group. And it's not just the cost of the drugs, I assure you, because almost all of the drugs we use are generic and they're cheap as chips. It's mostly the fact that these people consume far more in terms of healthcare far more healthcare usage, and their usage of all of primary and community care goes up, but most importantly, secondary care. I mean, if you have chronic pain and you have any sort of inflammatory arthritis or osteoarthritis or neuropathic pain, particularly if it's associated with something like diabetes, you're likely to have the complications of those conditions as well. And that is why these people have a far greater inpatient residence than those who do not have chronic pain. I suppose what I'm really saying is that chronic pain is almost a biomarker for all of the other diseases that they've got. If you look at those last two bullet points there, look at the cohort, they use 4.5 million appointments over the 3 years, costing nearly £500 million. Primary care accounts for nearly 2/3 of the activity, but only 13% of the cost. And that's because the cost of that activity, because that's so massively well weighted to the cost of being admitted to hospital. So as I've said, it's a really common condition, chronic pain. There are actually far more people with moderate to severe pain consuming health resources than I think any of us had really realized. And what's even more fascinating is it's the condition in the over 50 that causes the most usage of healthcare above everything else, which in itself is quite a finding. There's a silent epidemic in all age groups over 50, and especially in areas of greatest deprivation. And as I've said, I'm concerned that many minoritized communities may not be consulting GPs at all. They're using other alternative practitioners. And if they do consult a GP, then they may not be prescribed analgesics at the same rate as their other white counterparts. Now, you could argue that may not be such a bad thing given how awful the drugs are, but it's an important point. So this emphasizes the importance, I think, of delivering effective local community-based treatments much earlier in the pain pathway. And that, therefore, is likely to be associated with a reduced medicalization and the associated healthcare costs. And if you could deliver appropriate treatment earlier, then you would be able to greatly reduce the degree of disability that occurs over 3 to 5+ years. So PMPs, I am not going to say anything more about them. It would just embarrass me as well as you, in that it would demonstrate how little I know and how much you all know. But if you look at the last two bullet points, we took our 8-week pain management program that was initially delivered separately at UHBW and MBT and is now jointly delivered by the two pain units, mostly based at North Bristol. And we have always traditionally looked at outcomes at 3 months after they finish the program. We are now debating whether to do it at a much later time point, like a year as well. But you can see significant reductions, and I mean really significant reductions, 0.001 or less in anxiety and depression, pain interference with daily living, and an overall 21% improvement in overall health as measured by EQ5D. So I don't think there's any argument that certainly in our hands, the 8-week PMP, which isn't the full 12-week MDT, the 8-week one is normally delivered by one healthcare professional and a patient tutor with considerable lived experience of chronic pain. But those sorts of 8-week programs, which obviously bring together both education and therapy, I think has good validity. There's a number of publications using them, which we have contributed to some of them. But the thing that really worries me, and as Jeremy knows, why I have really focused on this with other colleagues, and you'll see later who they are. But I mean, the main reason for doing this is that if you could intervene with a pain management program earlier in the patient journey, preferably locally delivered rather than having to come up to the hospital, then it seems to me that the likelihood of that improving outcomes in the short and the long term must be considerable. And that is essentially what we've been focusing on. But here's the bit that really depresses me. At the moment in BNSSG, so that's predominantly the 2 acute trusts, your time from when you are first referred by a GP to the pain team to be seen to the time where you actually finish a pain management program is now at 2 years. So it's almost a year to see a pain consultant, and then it's almost another year until you can complete a PMP. Now, if that sounds bad enough, consider this. The average time that patients bounce around in primary care, seeing their GP repeatedly, getting drugs and more drugs, is 3 years. That means from the time a patient starts prescribed medication to the time they get a pain management program is 5 years. And during that time, obviously, the patients will become far more disabled, far more medicalized. The chances of them being on opioids are much greater with all of the problems that go along with it. So that was the rationale that really focused the work that I was doing. It brought together with the work that Jenny Lewis at UWI and at RNHRD is doing, her work on inequalities in the way that healthcare is provided dovetails obviously and beautifully with what I'm doing. And that is why we have brought together some of our work programs and why she is co-PI on the grant application that I'm going to tell you about. So this was a pain pilot for exactly what I've been talking about, delivering an 8-week PMP in a community setting. We wanted to explore the feasibility. And I advised on this, but it was led by Hazel O'Dowd at NBT and one of her team, Jeanette Moxon. So the main thing we wanted to do was to be quite frank, cut out doctors altogether, cut out consultants altogether. We wanted to join up the 8-week PMP in the community with directly a search. For exactly the same algorithm I've been telling you about, could we link the two? And that's what we tested. And the very short answer is yes, you can. So essentially what you do is you use the same search criteria based on pain medication. And Hazel, very sensibly, the first question we asked was that list picking up chronic pain? And the answer is yes. She reviewed the first 100 patients identified in this way, reviewed their notes, and more than 95% had chronic pain, which is reassuring. So we sent out one text message. It got sent by each GP surgery, and it got sent out to the patients without any explanation. any real backup. There was no subsequently being contacted to say, would you like to do this and explain it more? There was nothing from subsequent GP face-to-face contact saying, oh, I noticed you haven't done this. You really ought to think about it. But nevertheless, we sent this one text out to over 1,000 patients, of whom 13% responded. That tells you something. There's a huge unmet need. And if 13% are prepared to respond to just one text, we would expect that the actual pool out there of people who are interested and would want to respond. I mean, a lot of us, you get junk texts all the time. Some of them you don't even see. So this was obviously a test bed, but nevertheless, as I say, 128 responded, and they attended a 1-hour pain education session. They were all run face-to-face. 1 or 2 were delivered online. The outcomes of that, because we did an analysis, was that almost everybody was very highly motivated to explore their own pain further or to gain further support. Less than 5% of the entire population said they didn't think they'd be doing any more. We signposted them to all the obvious things: escape pain, vitamins, IACT services, and so on. 25% of people were very keen on booking a medication review with their pharmacist, and many of them expressed concerns about the medication not working or unpleasant side effects. Duh, it's not a surprise at all. So here was the really interesting thing. Half of the participants said that they wanted to explore a pain management service and a pain management program. So they were all referred directly. This did not involve a GP at all. And it did not involve a pain consultant seeing them first. They went straight from that through to the existing pathway we have for a pain management program. So they still got the 1-hour education session. I've told you about that. They then had a 1-to-1 assessment with the psychologist to check that they were eligible for a pain management program. And actually, at least a third of people are not, or they've decided it isn't for them. And the rest were then progressed into the 8-week pain management program and completed it. So we did that analysis, we published it, and it all looked good. And that was the basis for what we started to do. But what I really wanted to know was there any long-term follow-up data for pain management program? And the answer is there's nothing. It's a wasteland out there. There's a few from America from 25, 30 years ago, but that's it. No one is really doing long-term follow-up, or very few people. So we used our system-wide data set in a way that has not been done before. So we actually used it to get the outcomes. And this was not for business planning. This was essentially to produce the data to convince commissioners that this was worth doing. So we found the figures here. And what we're doing here is comparing those that completed the pain management program with those that did the 1-hour pain education session, but did nothing else afterwards, or rather, not nothing. They may well have attended vitamins and all the other things. We didn't at that point quantify it, but they did not do the pain management program. So those are the two groups we were comparing. And you may say, well, it's not a true control because they've done the 1-hour pain education session, albeit maybe 6 months, 12 months ago by now. But the reason you have to have that group is you've got to have two groups that are consented and have actually agreed to do this, and more to the point, are ready to be contacted to collect follow-up data. If you just took a true control population out there in GP land, where you never contacted them in the first place, but you know they meet the criteria, and you try and get follow-up data from them, you'll get nothing back at all. If you just contact people out of the blue and say, would you fill out these questionnaires? They're not going to do it. So you need to have them involved in the study to be able to do this. So that's how we did it. But you can see there the figures. A very significant drop in GP appointments in the PMP group compared to the education session. New referrals to pain clinics went down by 1/4. Community physio usage went down. Vitamins, talking therapists went down by nearly 90%. So in other words, these were a group of people who clearly benefited at the 2-year mark from the PMP that they had previously done. The costs of the drugs, as I say, are not great, but now look at the actual usage of the opioids. 84% reduction in cocodramol after PMP, over 80% reduction in codeine, 14% in gabapentin, 17% in pregabalin. So what it means is that the PMP is leading to long-term changes in prescribing and therefore a reduction in harm. So how would we scale this up, what we've done? Well, even with the small amount of follow-up data I've just shown you, this is still a very small group. We would need to have far more at-scale data to really make the case to NHS England, which is itself about to disappear, but to the Department of Health to say this should be done at scale across the country. We would need far greater evidence to do that. So as a result, Jenny and I, with a team in the University of Bristol ARC and with clinical colleagues from Bradford, have pulled together a large NIHR health services research, which is an actual implementation study. So essentially, we are going to be implementing this across the whole of the Western WWV, Western Wall and Villages PCN out in Weston, and one of the inner city PCNs in Bradford. Very different population, obviously. Weston is 97% white. Inner city Bradford is about 60% South Asian. More to the point, in Bradford, at least half of the PMPs are delivered in Urdu because there's still a very large population there that need it, but are not able sufficiently to speak English. So, what are we going to be measuring? Well, clinical outcomes and economic evaluation. So the things I've shown you before, reduction in pain interference, anxiety, depression, quality of life scores, reduction in the number and cost of primary and community and secondary care, reduction in harm due to opioids and gabapentinoids. And here's the big one that's never been looked at before. If we can show that having done a PMP a couple of years later alters your ability to stay in work or to go back to work, that would be a major finding. The Department of Work and Pension would bite our hands off for that. So, you know, it's, as I say, not been done at scale before, and certainly not in the UK. So that's the last arm of the study we'll be doing. If it's positive at both sites, or even if it's positive at one but not the other, which in itself would be fascinating, then I think there would be a much, much stronger case for doing this in primary care, cutting out the hospital clinics altogether with a reduction in waiting time. And that would also, to state the obvious, cause a major shift and expansion in the way that we currently provide both primary and secondary care chronic pain. And if you want a really good example of how this can work, you need to look at Nottingham. I was not aware of what they did there in as much detail as I should have been, but having spent a considerable amount of time with the two clinical leads there, what they're doing is very, very similar to what we are doing. They again effectively cut out secondary care altogether. It's direct referrals from GPs and healthcare professionals. So they don't have the algorithm. So it's still down to the individual clinician to decide whether to refer. But the other thing they haven't collected really, or at least been published, is their outcomes. And I'm going to be going through that data with them, and then we'll see what we see from there. So, in terms of my clinical applicants on the grant, as I said, Professor Jenny Lewis will be my co-PI. We'll both be leading the study, not least because by the time, if this gets awarded and finished, I'll be 73. So I might drop dead before then. So it's important to have a younger person to carry on. My pain consultant colleague, Christina, who works predominantly out in Weston, and who has been leading with Hazel O'Dowd much of the pain management program and other support services. Jenny has been working on patient cafes out there. Christina has been working on better education for GPs and primary healthcare professionals. Hazel, who runs the pain management program for Bristol at NVT, and Shazad, who is now a close colleague who works in community pain management at Bradford. So thank you very much indeed. I'm very happy to take questions.
Thank you, David. Much appreciated. And there's a virtual round of applause, I'm sure, rippling through the audience. So there have been some questions, and if it's all right, I will slightly put these together and put them to you.
Sure, go ahead.
So I think Mairead was one of my colleagues. Mairead was caught by the sheer cost of NHS appointments associated with this. It was something like it was a huge number of appointments costing a great deal of money. Do you have any breakdown of what type of appointments those were and which ones were really sort of sucking up the funds?
The answer will be that it's always secondary care that is the more expensive. You know, a secondary care new consultant appointment will cost far more than an equivalent GP appointment. And if you're going to do a pain management program, then I'm not sure there is one standard tariff for that. I think some centres would charge for 8 separate sessions. For some, if their block contract is such that it's about seeing new patients, then you may not even get that much tariff for a follow-up. So it's very variable. But nevertheless, in terms of the sheer numbers of appointments, it will push things up. But the majority of them were primary care in terms of the numbers. GPs, physios, OT, vitamins, MSK in all of its varieties. So that's the numbers. In terms of the cost, as I say, all of that is dwarfed if someone has to be admitted to hospital. And again, therefore, you get into this almost sterile discussion of, well, if someone's got chronic pain, they're on the chronic pain drugs, but they've actually come into hospital because, of course, they've got diabetes and they've got a big leg ulcer. Do you say that is a chronic pain visit or not? And the answer is it's both. So it will skew the figures slightly. I'm not sure if that answers your question fully, Mairead.
And I suppose also there's the question of, is it a normal distribution, or could it be possible to go through your data and pick out a minority of people who are frequent flyers or ED attenders?
We have done all of that, absolutely. So there is definitely a population, probably 3 to 5%, who are frequent flyers or frequent attenders. Both sound pejorative. I don't particularly like them, although we all use them. But, you know, they are people who multiply attend in primary care. They will very often have 3 or 4 long-term conditions. They will be on multiple drugs, multiple treatments, and it's not surprising they get confused by it all. And at times will mistake their drugs and end up unintentionally taking an overdose, you know, producing harm. But I think that it's very difficult to separate those out in the morass of primary and secondary care. It's slightly easier if you're just saying, well, how many people attend the emergency department on more than X occasions and so on. And certainly you will have 10 to 15% of those people who very repeatedly attend. They will be coming in with non-specific abdo pain or non-specific chest pain. Those are by far the 2 most common causes of people coming. And again, that is the group where, if I suspect, if you could intervene earlier and come in with a focused pain management program and maybe even a full psychological approach for those individuals to try and alter their behavior, it may feel like it's very labor intensive. But in terms of the saving at a population level, because so many people, those individuals are attending so many times to the emergency department, it is cost effective.
Brilliant, thank you. So, David, you've mapped out the ethnicity mix in your local population. Do you know the ethnicity mix attending pain clinics, and do they match?
I know the answer because I asked that question specifically, and I went back over 5 years. We pulled out all of the new patients we had seen collectively, the 6 consultants, and then I asked for the breakdown of ethnicity, and I asked for the breakdown of deprivation. The answer was the complete opposite of what I feared. I feared that we would find an underrepresentation. Certainly for the majority African and Caribbean populations and the South Asian populations, they were both overrepresented. And again, you can say that's a good thing, or you can say it's a bad thing. They're a good thing, I suspect, because they are more likely, therefore, to be directed appropriately into a pain management program. Or you could say that that's because they're on vast amounts of opioids and the GP has got worried about them. So, as always, it will be a heterogeneous mix.
Thank you. Brilliant. So we've got a question from Stephanie coming in, who is, I think she's asking for a little bit more detail about who delivers the pain programs. So
you mean the 8-week pain management program. So just to be clear, what we are planning on delivering in the grant, which we'll call a community pain management program, purely because it's going to be delivered in the community, is identical to the existing secondary care pain management program, the 8-week program. And that is delivered by one healthcare professional and one very experienced patient tutor.
And healthcare professional could be any member of the MDT, could be physiopsychologist, could be...
Absolutely. It very often varies between the PMPs who does what.
And you have this extraordinary collection of highly skilled peer facilitators and peer educators, and that's taken quite a lot of time to build up in
big time
in Bristol, absolutely. I think, hasn't it? But I imagine most people don't have that.
I would guess probably not. No, I mean Lambeth and King's Health Partners, who I work closely with, trying to do something similar in the keep on getting this wrong, African Caribbean population. And theirs, however, was far more educationally based rather than therapy based. But nevertheless, if you looked at all the way through their pathway, the outcomes they measured, they were remarkably similar to our findings in the clinic.
Brilliant, thank you. Can I take us just briefly back to epidemiology, David?
Sure.
Because we've got with Jenny Lewis, we've been looking at ethnicity, and we've been looking at large publicly accessible data sets, and such as Biobank and the English Longitudinal Study of Aging. And I suppose one thing that comes through is sometimes they have a disappointingly small number of non-white participants. And the other thing is that there's no standardization in terms of how we define chronic pain or even understand pain impact. I mean, if you had words of wisdom for somebody designing the next bloody huge Biobank-esque sort of large study, which would collect really meaningful data from huge numbers of people, do you know how you would ask questions about pain or ask questions about pain impact or define it?
There's a much broader question here, Jeremy, and that is, why is the 500,000 Biobank, UK Biobank, why is it almost exclusively white? So that's a major problem. As you probably know, there is now a new NIHR cohort called IBO, Improving Black Health Outcome, which we're actually delivering across Bristol based around the clinical research facility, which is much earlier stage research. So we are attempting to address that imbalance. But when you're setting up a cohort study, whether or not you then phenotype them for chronic pain or anything else, by the time you get to do that phenotyping, you've collected the cohort already. So that is a problem. What really is needed for setting up new large cohort studies is in real time to start analyzing the ethnicity, the deprivation mix, and ensure it mirrors the population that you're attempting to recruit these individuals from. No way, shape or form was that done for UK Biobank, and most people would say, I really wish we had done. But it probably wasn't possible when they set it all up about 15 years ago now. Certainly not in the way real time that we can do it. So I think there's something about picking your cohort. I mean, obviously there will be smaller cohorts. For example, yours. I've just been discussing with my colleagues whether or not we could pull together a large cohort across both the Bristol Trust of everybody that's had a spinal or a nerve therapy. So that would include injections, radiofrequency ablation, and so on. We've probably across the two got at least 1,000 patients. You know, you could collect a very significant and interesting cohort around that and then look at all of the things we've been talking about. And the question is it worthwhile doing? It depends what the questions are, and therefore can you get the answers? So I think cohort studies and chronic pain phenotyping, it's not really going to get that much better. I think the new algorithm that the Lambeth team have developed, which, as I say, we are in the process of rolling out at both centres, Bristol, Somerset, South Gloucester, and Bradford. And I think it will be interesting to see how it does. Having done it just first with the drugs and now with a much wider algorithm, I'll be fascinated to see the difference in terms of the percentage. I'm not really answering your question. I am to some extent quite deliberately wittering because I don't have an answer.
Well, it's interesting though, isn't it? Because the biobank stats are so wide, it feels like there needs to be something done in terms of oversampling or more community engagement or all of the above. So,
as with all things, Jeremy, it's easy to be wise and adventurous.
Yep. Okay, well, look, I'm just going to give a last call out to see if anybody else wants to put in a final question for David. I'm anticipating that whether there's any furious last minute typing happening here. Give it a moment. Well, it does not look like it. So, and it looks like the gratitude is coming in, David. So, so thank you very much for attending so many times and then finally coming to speak. And so just let me clarify.
It's been a great pleasure.
Well, and the HSDR really grant, is that in? Has that been accepted? Or
25th of January is when it goes. Okay. So we'll see what we see.
Oh, well, huge good luck. Thank you for coming, David. Merry Christmas to you, and Merry Christmas to everybody on this call. Thanks a lot, and we hope to see you again in 2026. Okay.
Bye.
Thank you all, guys. See you. Bye.